Imagine you are rushing a child to the emergency room.
Oh, God, yeah.
Right. Their face is just swelling uncontrollably. Or maybe they're, curled into a ball, just screaming in agony from this sudden, severe abdominal pain.
Like a nightmare.
It really is. And it looks exactly like a terrifying allergic reaction.
Yeah.
Or maybe an acute case of appendicitis.
Which is exactly what the doctors think, right?
Exactly. So the doctors jump into action. They administer all the life-saving allergy medications, epinephrine, heavy steroids, antihistamines.
Standard protocol.
Right. Or they start prepping the kid for emergency abdominal surgery.
But
as you watch the clock tick down, nothing happens.
Wow.
Yeah. The allergy meds do absolutely nothing. The swelling just keeps growing. And today, we are decoding that exact medical mystery.
It is, it's a nightmare scenario for a parent. And frankly, it's just as terrifying for the ER physicians.
I can imagine.
Because they're treating what they think they see. But the underlying biology of what's happening to that child is, well, it's playing by a completely different set of rules.
So we're pulling our insights today from a really comprehensive 2026 document. It's published in the journal Allergy.
Yeah, the new guideline.
Right, the International Guideline on the Diagnosis and Management of Pediatric Patients with Hereditary Angioedema. So our mission for this deep dive is to unmask this rare, basically invisible and potentially life-threatening condition.
Hereditary angioedema. Or HAE for short.
Yes, HAE. We want to understand how it so perfectly mimics everyday childhood ailments. And most importantly, how modern medicine is radically shifting to empower these kids to, take charge of their own survival.
That shift from viewing pediatric patients as fragile entities to active, capable partners in their healthcare, it's one of the most profound changes in this new guideline.
It really is.
But to appreciate how we got there, we really have to start at the cellular level.
Okay, let's unpack this. Because to solve the mystery of why standard emergency treatments are failing that child in the ER, we have to understand what is physically happening inside the body.
Right, the actual biology.
Yeah. And while reading through this guideline, I just kept picturing a plumbing analogy.
Okay, I like that.
Specifically, like a massive commercial fire sprinkler system in a building.
Oh, that visual works perfectly for the human immune and inflammatory response.
You think so?
Definitely. When there is a fire, say an injury or, a pathogen entering the body, the sprinkler system turns on, right?
Right.
Fluid rushes into the affected area and it isolates the damage. It does its job.
But in a normal building, there is an off switch that, shuts the water down once the fire is out. Otherwise, the building just floods.
Exactly.
In a child with HAE, that off switch, which is a very specific protein called C1 inhibitor or C1-INH, is either completely missing or it's just broken.
And what's fascinating here is the genetic cascade that causes that broken switch.
Right, the genetics.
Yeah, this entire condition traces back to a mutation in a specific gene called the SERPING1 gene.
SERPING1.
Because of this single mutation, the child's body either, fails to produce enough of the C1 inhibitor protein, or the protein it does produce is structurally dysfunctional.
So it's there, but it's useless.
Exactly. It floats around in the blood, but it just doesn't do its job.
And without that functional inhibitor, the sprinkler system just runs wild.
Totally wild.
But it's not just a generic immune response, is it?
Far from it. Without the C1 inhibitor regulating the system, the body goes into hyperdrive. It overproduces a very specific, really powerful peptide called bradykinin.
Bradykinin.
Yeah, and bradykinin acts like a biochemical key. It travels through the bloodstream and binds to specific receptors called B2 receptors that sit right on the walls of your blood vessels.
Like unlocking a door.
Essentially, yes. Yeah. When bradykinin binds to those receptors, it signals the cells lining the blood vessels to relax.
Oh, wow.
Yeah, they open their junctions. The vessels become hyperpermeable. Think of a solid garden hose suddenly turning into a porous soaker hose.
So it just leaks everywhere.
Right. Fluid leaks directly out of the bloodstream and floods the surrounding tissues. That localized, massive flooding is what we call edema.
The details in this 2026 guideline about how this actually presents in children are just wild.
They really are.
For starters, the symptoms usually don't even show up until a child is around 10 years old.
Which is so late for a genetic condition.
Yeah. And the swelling itself is uniquely deceptive. It's subcutaneous, meaning it's deep under the skin. But surprisingly, there's no itching.
Right. No hives at all.
The lack of itching is a crucial diagnostic clue, isn't it?
It is huge because when we think of swelling, society has basically conditioned us to associate it with a histamine reaction.
Like the classic itchy red raised highs of an allergy.
Exactly. But bradykinin doesn't trigger those itch receptors. It just causes a dense, tight, heavily swollen, and often, very painful accumulation of fluid.
And before the swelling even begins, the body throws up this bizarre warning sign.
Oh, the rash.
Yeah, the guideline points out that roughly half of pediatric patients, like 42 to 58%, develop something called erythema marginatum.
Right.
It's this prodromal rash that shows up before the main attack, and it looks like a distinct map-like pattern drawn on the skin.
It serves as the earliest visible sign that the vascular permeability is beginning to shift.
Like a warning flare.
Exactly. The fluid is just starting to leak.
But I mean, if I'm a parent and I see a weird map-like rash on my kid, I'm reaching for a tube of hydrocortisone or, licobenadryl.
Of course you are.
I am definitely not thinking, oh, my child's blood vessels are currently turning into a soaker hose.
No one thinks that.
It is terrifying how deceptive this is. And the swelling doesn't just happen on an arm or a leg. It can happen in the upper airway.
Which is incredibly dangerous.
Yeah, it causes life-threatening asphyxiation.
Yeah.
The throat just silently swells shut. Or, and this is the part that blew my mind, the swelling happens inside the submucosal tissue of the intestine.
Yeah, the intestinal wall literally becomes engorged with fluid. The tissue swells so dramatically that it narrows or even completely blocks the intestinal tract,
Causing severe colic, nausea, vomiting, and even a dangerous drop in blood volume.
Hypovolemia.
Right, because so much fluid is exiting the blood vessels. It perfectly mimics acute appendicitis or a bowel obstruction.
Which is terrifying for an ER doc.
Which brings us back to our nightmare ER scenario.
Oh,
so what does this all mean? Wait, I actually need to stop you there. I really want to push back on this medical reality for a second.
Sure, go for it.
If a kid's throat is swelling shut and looks exactly like anaphylaxis, how is it biologically possible that an EpiPen does literally nothing?
It's a great question.
Aren't all sudden allergic swellings triggered by the same fundamental thing? Like, why wouldn't a heavy dose of epinephrine save their life?
If we connect this to the bigger picture, it all comes down to the fundamental difference between two entirely separate chemical pathways. ER doctors are trained to spot and treat mast cell-mediated allergies. That is your classic anaphylaxis.
Like a peanut allergy or a bee sting.
Exactly. In those cases, mast cells release histamine, and that entire histamine cascade responds beautifully to antihistamines, steroids, and the epinephrine inside an EpiPen.
It's the standard medical playbook for a reason. It works.
It works for histamine, but HAE is bradykinin-mediated. It's a totally different chemical pathway operating on totally different receptors.
Oh, wow.
Yeah, using an EpiPen on a bradykinin cascade is like trying to put out an electrical fire with a bucket of water.
That is a terrifying visual.
Epinephrine and antihistamines physically cannot stop bradykinin from binding to those blood vessels. They are just the wrong tools for the job.
Meaning, if you give a kid an EpiPen for what looks like a severe allergy and the swelling doesn't even slow down,
yes,
the medical team needs to immediately stop thinking allergies and start thinking bradykinin.
Exactly. That non-response to typical allergy medications isn't just a clinical failure. It is a massive flashing red flag for HAE.
And ignoring that flag leads to the rampant misdiagnoses highlighted in the guidelines.
Absolutely.
Like intestinal swelling gets written off as viral gastroenteritis. Or worse, children are rushed into the operating room for completely unnecessary appendectomies.
Yeah, only for the surgeon to find a perfectly healthy appendix next to a swollen bowel.
Unbelievable. And the erythema marginatum rash is routinely mistaken for regular hives, even though it doesn't itch.
The guideline is incredibly firm on this point, actually. It urges pediatricians and ER doctors to test for HAE in any child who comes in with recurrent, unexplained, colicky abdominal pain.
Even if there is zero family history of the disease, right?
Yes, that is a vital recommendation because considering about 25% of HAE cases are de novo mutations, meaning the mutation happens spontaneously in the child's genetic code. It was not inherited from either parent.
Oh, wow. So a negative family history can give a doctor a very dangerous false sense of security. So once a doctor actually suspects this missing off switch, What is the actual diagnostic odyssey? Like, how do you prove it?
Well, the gold standard involves specialized biochemical blood testing. First, they look for a specific complement protein called C4.
C4, okay.
Right, which is used as a highly effective screening tool because it's almost universally low in patients with HAE.
Okay, so if the C4 is low, then what?
Then they move to definitive testing, which measures the actual C1 inhibitor levels. They look at two things.
The antigenic and functional levels.
Yeah, got it. The antigenic level, which is the sheer quantity of the protein in the blood, and the functional level, which measures how well that protein actually works.
But doing this for newborns is incredibly complex, isn't it?
Yeah.
The guideline dedicated a whole section just to the challenges of testing infants.
Yeah, you simply cannot rely on those standard complement blood tests in the first year of a child's life.
Why not?
Because a newborn's immune system, specifically the complement system, is profoundly immature. The proteins just haven't reached their adult baseline levels yet.
Oh, I see.
So if you test a 2-month-old and find low C1 inhibitor levels, you have no way of knowing if they actually have HAE or if they're just, a normal infant whose immune system is still booting up.
Which is why the guideline leans so heavily into genetic testing for newborns.
Exactly.
Instead of waiting a year and leaving the parents in limbo, they take umbilical cord blood right at birth to look directly for that SERPING1 gene mutation.
They completely bypass the immature immune proteins.
That's brilliant.
Yeah. If the specific genetic mutation running in a family is already known, genetic testing at birth provides an immediate definitive answer. The parents know on day one.
But what if it's a spontaneous mutation?
If the family mutation isn't known or it's a spontaneous case, the diagnostic window often forces doctors to wait until the child is at least a year old to get accurate biochemical blood tests.
That's a long year. So once you finally solve this genetic puzzle and get the official diagnosis, I imagine the relief is pretty short-lived.
Very short-lived.
Because now you actually have to keep this kid safe. Here's where it gets really interesting. How do you navigate a world full of triggers if you can't just tell your kid to avoid peanuts or dairy?
This raises an important question, doesn't it? How do we balance absolute safety with a child's fundamental right to a normal, active childhood?
It seems impossible.
The psychological burden here is immense.
Because the triggers for HAE are bizarre. You're trying to navigate completely standard life events. Like the guideline lists things like minor mechanical trauma, just a kid bumping their knee on a playground.
Or routine dental procedure.
And even just emotional stress.
Yeah, the unpredictability creates this constant hovering anxiety. I mean, a trip to the dentist to get a simple cavity filled that can trigger massive life-threatening swelling in the upper airway solely because of the mechanical pressure of the dentist's tools in the mouth.
That is terrifying.
Or a highly stressful math exam at school could trigger a debilitating abdominal attack a few hours later.
And just when a kid might be getting a handle on all of that, puberty throws a massive hormonal wrench into the gears.
Oh, definitely. Hormones are major modulators of the bradykinin system.
I read that the guideline includes crucial medical warnings specifically for adolescents.
Yes. For teenage girls, estrogen-containing oral contraceptives are strictly warned against.
Because it triggers it.
Estrogen can dramatically trigger or worsen HAE attacks. They must rely entirely on progestin-only options to avoid flooding their system with a known trigger.
Wow. And there was also a strict warning for all pediatric patients to avoid ACE inhibitors, which are, a very common type of blood pressure medication.
Right. ACE stands for angiotensin-converting enzyme. Interestingly, that enzyme is one of the key mechanisms the body naturally uses to break down and clear away excess bradykinin.
Oh, I see where this is going.
Yeah. If you prescribe an HAE patient a drug that inhibits ACE, you are medically disabling one of their only remaining pathways to clear bradykinin out of their blood.
So the bradykinin just builds up.
The result can be catastrophic, prolonged swelling.
So how do we actually treat an attack when it happens? Because the 2026 guideline breaks treatment down into two main categories, right?
Correct. Acute and prophylactic.
Right. Acute, which is on-demand treatment when an attack is actively happening, and prophylactic, which is preventative. And the pharmacology they use now is incredible.
It really is.
If we go back to our fire sprinkler analogy, how do these drugs actually stop the flooding?
Well, the therapeutic landscape has completely revolutionized in recent years. For acute attacks, the goal is either to replace the missing off switch or to physically block the water from leaving the pipes.
Right.
We now have intravenous plasma-derived C1 inhibitor, which literally infuses the missing protein directly into the blood.
You are handing the body the off switch it couldn't build.
Exactly.
And then there's subcutaneous icatibant.
Right. Icatibant is a synthetic bradykinin blocker. It races to those B2 receptors on the blood vessels and sits on them, blocking the bradykinin from attaching. In our analogy, it's like running around the building and rapidly capping all the individual sprinkler heads so the water can't get out, even though the system is still technically turned on.
The guideline also highlighted a newer oral medication called sebetralstat for adolescents.
Yeah, sebetralstat is fascinating because it targets the cascade much earlier. It inhibits an enzyme called plasma kallikrein.
Plasma kallikrein.
Right, which is essentially the machine that manufactures bradykinin. By inhibiting it, sebetralstat shuts off the main water valve before the water even reaches the sprinkler heads.
It stops the production of bradykinin before it spirals out of control.
Exactly.
And for long-term prophylaxis like preventing attacks from happening in the first place, we have monoclonal antibodies like lanadelumab or garadacimab.
Think of monoclonal antibodies as microscopic, custom-built bouncers that constantly patrol the bloodstream.
Bouncers. I like that.
They are engineered to specifically target and suppress that plasma kallikrein enzyme 247. They provide a constant, hovering suppression of the cascade, allowing these kids to go weeks or months without a single attack.
But the pharmacology is only half the story. The part of the guideline that really stood out to me wasn't just the drugs, it was the focus on how these drugs are administered.
The self-administration piece.
Yes. The task force strongly recommends training children for self-administration and home treatment by the time they reach early adolescence.
That represents a massive paradigm shift in pediatric care.
It has to, right?
Absolutely. Historically, an HAE attack meant a panicked, immediate rush to the hospital for intravenous therapy by a medical professional. The child was essentially a passive victim of their disease.
Just waiting to be saved.
Right. Now, the guidelines advocate for teaching a young teenager how to self-administer a subcutaneous injection or even mix and administer their own IV therapy.
At home, at school, on a family vacation. It completely restores their locus of control. They don't have to live in constant fear of being more than an hour away from a major hospital.
Yeah, exactly.
If they feel that map-like rash coming on or the familiar tightness of a subcutaneous attack starting, they don't have to wait for an ambulance. They can intervene immediately.
The guideline explicitly states this is how you ensure rapid treatment and drastically reduce the psychological trauma of the disease.
Medically speaking, the faster you administer the targeted drug, the less severe the attack will be, right?
Exactly. Home treatment drastically reduces the overall morbidity of the disease. It allows them to just be teenagers.
But of course, the guideline also delivers a very sobering reality check regarding global healthcare disparities.
Yeah, that's the hard part.
All these incredible targeted monoclonal antibodies and bradykinin blockers. They're wildly expensive and often completely unavailable in low to middle income countries.
The task force had to confront the reality that for much of the world, these first-line therapies simply do not exist.
They had to provide clinical recommendations for physicians operating in heavily resource-limited settings.
Right.
And the backup plan they suggest is fascinating but also kind of terrifying. The guidelines suggest using fresh frozen plasma, or FFP, to save a child's life during a severe attack. But earlier when we were digging into the biology, I read that giving plasma could actually be dangerous.
It is a profound medical paradox.
How so?
Well, fresh frozen plasma is essentially a raw, unrefined mix of blood components. Because it is unrefined, it contains high levels of kinogens, the exact substrates that fuel the bradykinin cascade.
Wait, so by infusing it, you are theoretically dumping gasoline onto the fire?
Yes, it can make the swelling temporarily worse.
So why on earth would a doctor use it during an attack?
Because that raw, unrefined plasma also contains the missing C1 inhibitor protein. It brings the gasoline, but it also brings a massive fire extinguisher. In a life-or-death emergency, particularly a severe airway attack in a region without access to icatibant or targeted therapies, the benefit of supplying that missing inhibitor generally outweighs the risk of fueling the fire.
So the C1 inhibitor eventually gains the upper hand and stops the cascade.
It is a highly calculated risk to save a child from asphyxiation.
It's a stark reminder of how lucky we are in certain parts of the world to have access to modern targeted therapies, and how much critical work still needs to be done globally to bring that standard of care everywhere.
The disparity in care is unarguably one of the greatest ethical and logistical challenges highlighted by the International Task Force. The science is there, but the access is not.
So, as we wrap up this deep dive, let's look back at the journey we've just taken. We started with the terrifying mystery of a child swelling uncontrollably in the ER, unresponsive to the standard allergy playbook.
We unpacked the plumbing of the immune system, the missing genetic off switch, the bradykinin cascade, and the leaky blood vessels causing that invisible, non-itchy swelling.
We navigated the diagnostic odyssey, learning that recurrent colicky pain or a map-like rash should instantly trigger thoughts of a missing protein, not just stomach bugs or hives.
And finally, we saw how modern guidelines are literally putting the power back into the hands of these pediatric patients.
Right, teaching them to self-administer life-changing medication so they can reclaim their childhoods.
It is a brilliant story of medical evolution, moving from clinical misunderstanding to cellular-level precision.
And for you listening, why does this matter? Even if you never encounter a case of hereditary angioedema in your entire life, understanding how a rare genetic disease can perfectly masquerade as a common ailment, like an allergy or appendicitis, sharpens your ability to be a critical medical advocate for yourself and your loved ones.
Absolutely.
It reminds us that when standard treatments fail, we have to stop pushing the same buttons and start asking if we're even looking at the right machine.
It teaches us to question our deepest medical assumptions. If the clinical picture doesn't match the biological response, you must pivot.
And that leaves me with one final, provocative thought built directly on this 2026 guideline. The document relies heavily on genetic testing to catch this disease early, especially utilizing umbilical cord blood to find the SERPING1 mutation before the child ever experiences a symptom.
Catching it at birth is the ultimate form of preventative medicine.
But think about the trajectory of that technology. As genetic screening becomes faster, infinitely cheaper, and universally accessible, what happens next?
It's a huge question.
Could we eventually reach a point where we map and preemptively treat all rare genetic vulnerabilities right at birth?
Wow.
Imagine a world where the diagnostic odyssey, the years of painful misdiagnoses, the unnecessary exploratory surgeries, the sheer terror in the ER is completely eradicated before a child takes their first breath outside the hospital.
We would be moving from a reactionary medical system that waits for the fire to start to a truly anticipatory one that fireproofs the building.
It changes everything. Because suddenly, when that hypothetical child walks into the ER a decade later, the doctors don't have to guess if it's an allergy or a missing genetic switch. They already have the blueprint. The murky waters clear up, and the diagnostic landscape is finally illuminated. Something for you to ponder. Thanks for diving deep with us today.